Welcome to this series on abdominal wall hernia for medical students. This is the first video of the series and my name's Arrow. My objective is to teach you what I believe every medical student should know about abdominal wall hernia, and today's main learning objective is to define hernia and the relevant terminology. We're starting with this because there's often a lot of confusion around the terminology, and defining the terminology accurately is what everything else rests on. So I'm a core surgical trainee. I'm aiming for a career in general surgery. So I'm not a registrar or a consultant. So, I make my content as reliable as possible, but you can just need to appreciate that I don't have the most experience in the world. And these videos are made with no institutional affiliation. And I have to say this is for educational purposes only. It may contain mistakes. If you see them, point them out in the comments. And this is not a replacement for guidelines, supervision, or clinical judgment. Without further ado, let's start with the first learning outcome. Define hernia and relevant terminology. I'm going to make this in a question and answer format, so I'll give you a question. You can pause the video and see if you can give the answer yourself, and then afterwards I'll give you the answer according to me. First is, what is a hernia? This is an absolute classic question asked by every surgeon ever, so pause the video right now and try to answer for yourself. Now for the answer. Hernia is the protrusion of the whole or part of a viscus beyond its ordinary anatomical confines. That's the universal definition of hernia. And the talk is specifically about about abdominal wall hernia. So that narrows our definition a little bit. So in our case, the viscus is usually going to be bowel, omentum, or fat, although in theory it could be any intra-abdominal organ. Protrusion just means going through something, and the ordinary anatomical confines for our purposes are the abdominal wall, which is usually the anterior abdominal wall, but it can be the posterior abdominal wall as well. And this diagram that you see here is a diagram I drew myself about hernia. So here you can see a depiction of an abdominal wall. Here's subcutaneous fat. Here is the skin layer over the subcutaneous fat, and you can see this piece of small bowel going through this area here and herniating into this thing. Okay, I'm specifically using vague words because now we can define these further words. So defect, contents, sac, hernia, and hernial orifice. And all of those things can be seen on this diagram. So pause the video right now and try to define these. Okay, and then for the answer. A defect is the hole or weakness. The contents is the stuff that goes through that hole. And the sac is a peritoneal lining around the contents. So often what you have is you have a weakness, and then through increased intra-abdominal pressure you have these intra-abdominal contents that gradually push through, and they widen the weakness, which then becomes a defect, and they stretch the parietal peritoneum so that there is a sac, which is just parietal peritoneum lining the new place where the bowel has herniated. The hernia just kind of refers to the whole thing, so the defect, sac, and contents. And a hernial orifice is a real or potential site of herniation. So when we talk about hernial orifices, we're often talking about areas of the abdominal wall where there is inherently a bit of weakness, and thus they are sites where herniation might occur. For example, the inguinal orifices and femoral orifices, and the femoral canal, inguinal canal, and the umbilical area. Next, talking about the terminology that relates to hernial complications. So can you define reducible, partially reducible, and irreducible? Pause the video right now and attempt to define these. Okay, and now for the answer. Reducible means that you can push the contents back in temporarily. Hernia is a pathology for which there isn't a treatment other than surgery, really. So when we say reducible, we don't mean a hernia that can be pushed in, whose contents can be pushed in and they're there for good, because the defect is still there. So if you were to push this in, applying some pressure here from the outside, you would push it in, and perhaps the bowels would go through, but the defect is still there. So when you take your hands away, the contents would ping right back. But if you can temporarily push the contents back in, the hernia is reducible. Partially reducible means that you can only push part of the contents back in, but not all of it. So some of the contents are sort of sliding back and forth. And irreducible means, despite making efforts to help reduce the hernia, you still cannot push the contents back in. Now, there are some specific further terms that I would like you to define, which are acutely irreducible, chronically irreducible, obstructed, and strangulated. Pause the video right now and try to define them. Now for the answers. An acutely irreducible hernia is one which used to be reducible, but has within an acute time frame become irreducible, and is often associated with the onset of new symptoms. A chronically irreducible hernia is a hernia that has been irreducible for a long time, and making this distinction clinically, which comes from your history, is important because that tells you about the urgency of surgical intervention. Obstructed is a hernia where the defect is narrow enough that it is compressing the lumen of the bowel, causing bowel obstruction. It's usually small bowel obstruction, but it can be large bowel obstruction as well. So it's specifically, the radiological definition would be a patient with bowel obstruction, with a small bowel obstruction or large bowel obstruction, with the transition point at the hernia, at the site of the hernia. But the clinical definition is a patient in whom you suspect bowel obstruction, who also has an irreducible hernia, and then you'd seek imaging to confirm or refute that, or take the patient to theatre, depending on the situation. Strangulated means that there is venous engorgement, so venous occlusion and engorgement of the veins, and basically venous ischemia. So what would happen is, if the pressure here in the defect is so high that it's pinching also the veins, and veins are pinched before arteries because veins are a lower pressure system, then what happens is you get blood coming in through the arteries, no blood coming out, and you get massive venous congestion here, and that can actually cause ischemia of the contents of the bowel. So strangulation is one of those complications of hernia that we really look for and need to have a low index of suspicion for. This is just really for fun, this image. I took that image that I created and I gave it to Gemini, and I said, try and make this into a more realistic diagram, and it got some things quite nicely. Well, it's labeled this wrong. This should be mesentery. This looks like quite realistic bowel, and there's some of the you've got the mucosa, submucosa, muscularis, and serosa layers, which is quite nice, and some of these labels are just completely wrong, like parietal peritoneum. No, that's clearly muscle that you've drawn there. But I just thought this was funny, just putting this here. I mean, these labels are wrong, so don't use this. But I thought it was funny to see how well AI could translate my image into a more realistic format. Let me know what you think in the comments. So, what about incarcerated hernia? Can you define that? Pause the video and try and define it. This is kind of a trick question, because this term is actually not endorsed by the European Hernia Society anymore, because it's been used inconsistently. So when people talk about an incarcerated hernia, sometimes they mean an acutely irreducible hernia, sometimes they mean any irreducible hernia, and sometimes they mean a hernia where you suspect strangulation or obstruction, and sometimes they refer to, I think the most correct technical definition is a hernia whose contents have become adherent to the sac, which is purely an intraoperative distinction. So for those reasons, if you use the term incarcerated, you go straight to jail, okay? So it's best to use the terms that I have outlined earlier in this video about the degree of reducibility and the timeline of reducibility, because those things are going to be better used because they're going to be used more reliably. So then we all have an idea of what we're talking about when we're talking about these patients. Okay, I hope that was useful for you guys. If you have any questions, please put them in the comments. I'm going to try and answer them, and I'm going to be making more videos about hernia in the future and other general surgical topics. So thank you very much for watching. My objective was to teach you what every medical student should know about abdominal wall hernia. This was but one of the learning outcomes that we will cover, and this was about defining hernia and the relevant terminology. These are some of the sources that I used, and that's all, folks. Thanks for watching, and come back for more. Bye bye.